Okay. Then after 2 to 3 weeks, as I said, it has got a special interest liking towards certain tissues like skin. So this is erythema marginatum and the nodosum, it's a nodules, and then you have arthritis. When you carditis is a very important area. As I said, all the 3 layers of the heart can get involved. All the 3 layers. The carditis, 90% of the carditis patients are very young people, less than 3 or 4 years of age, and 30% are below, above 3 or 4 years, 10 years or 12 years. So the younger the patient, the more are the likelihood of they getting involved of the myocardium. So they come with chest pain. If the myocardium, if the heart is involved, they may come with chest pain. They may come with palpitation. Sometimes they may come with acute MR, acute mitral regurgitation. You should know what is the cause of acute MR. This is one cause, rheumatic fever. In rheumatic fever, the mitral area gets involved and it will cause, because of this antigen antibody reaction, the myocardium gets involved and patient can have acute MR, and patient may come in acute heart failure also. Some arrhythmias, some patient may come with MR is because of vasculitis. Valvulitis. Valvulitis is valve is involved. Your mitral valve cusp gets involved. So that is acute MR of acute rheumatic fever disease. So chest pain, palpitation, heart failure, MR, and there may be a systolic, pansystolic murmur of typical of acute MR with radiating to the axilla. So in the skin, we have erythema marginatum and subcutaneous nodules. And these nodules and marginatum, you know that erythema marginatum is the central ring-like reddish lesion will appear on the skin. So mainly it is these regions are seen mainly on the trunk and extremities, but they are rarely seen on the face. And chorea, of course, you have heard about chorea, Sydenham's chorea, otherwise called as Saint Vitus dance. Saint Vitus dance or Sydenham chorea. A few patients with acute rheumatic fever also. This is one of the criteria. How will you diagnose this? How will you diagnose acute rheumatic fever? Of course, there is no specific test for rheumatic fever. Only thing is the ESR with rate. This is an active phase reactant. ASO titer is raised, and culture you may, as I said, only 25 to 30% of the times you may grow the streptococcus on culture. And 2-deco, if you do a 2-deco, you may have features of either pericarditis, myocarditis, or endocarditis, or valvulitis in the form. Usually, mitral valve is the commonest valve that gets involved. So how will you treat acute rheumatic fever? How will you treat? This rheumatic fever itself is become rare now, but still any young people less than 15 years coming with a history of sore throat followed by these features of joint pain, skin nodules, and myocardial involvement, you can strongly suspect even till today. Though it is less common, but you can still suspect and try to investigate. So treatment is, of course, very simple. Is just penicillin injection, benzyl penicillin 1.2 million units intramuscularly you have to give. Patients who are sensitive to penicillin, you can give erythromycin or some cephalosporins you can give. And of course, rest and symptomatic treatment of IV fluids and paracetamol. Aspirin is a wonder drug. Aspirin, the good part of aspirin is aspirin not only reduces the fever and joint pains, but it also is a diagnostic. If the severe joint pains subside dramatically in 24 hours, if you are giving and the dose of aspirin is little higher in acute rheumatic fever, and when you are strongly suspecting acute rheumatic fever and giving aspirin treatment for these people, if the joint pains subside within 24 hours, that is the diagnostic indirect evidence that we are dealing with a case of acute rheumatic fever. You should remember that. But we are really afraid of giving such a high dose, but nothing will happen. You can still give. And sometimes we may also add steroids if you are suspecting pericarditis or something like that. In the steroids, prednisolone or any other steroid you can give. So that is about acute rheumatic fever. This is acute rheumatic fever if the patient is not identified, diagnosed, and treated properly. If you give penicillin for 10 days, the acute rheumatic fever will completely subside. All these complications that it is causing will become normal. But if you are failing to identify this, a few 50% of the acute rheumatic fever patient, 50% of the patient will have a long-term effect after 10 or 15 years because of this immune-related reaction. They develop valvular lesions in the heart. So they come with rheumatic heart disease. All the time we are dealing with acute rheumatic fever. Now we are dealing with the patients will come after 10 to 15 years. Usually they begin to come from the age of 25, 30 or sometimes 40 years. So 10 to 20 years it will take for the heart to get involved in the form of valvular lesions. So therefore identifying and treatment is very, very important in acute rheumatic fever patients. And in rheumatic fever, carditis, 90% of the times it is only mitral valve is involved. They have some special liking towards mitral. 90% of the time, mitral valve is involved. Then followed by aortic, tricuspid, and pulmonary. That is the order of involving. And 25% of the time, it's only mitral stenosis. Mitral valve is very common, 90%, and 25% of the time, mitral valve alone, and 40% of the time is mitral stenosis alone, and 40% of the times both stenosis and regurgitation can be there. In both lesions can be there. What is the pathology? So as I told you, the antigen-antibiotic reaction, which will have a long-term immunological effect, it will cause fibrin deposits and tissue damage on the valves. And it can also cause pericarditis and myocarditis, as I told you. The valves are damaged. I'll draw a small figure itself, and then I'll show you the heart model. If you look at this, is mitral orifice. This is a two mitral orifice. Two leaflets are there. This is one leaflet, and this is another leaflet. This is a closed mitral, and when it is open, so normally when it is fully open, when your left ventricle is dilated, the orifice size is 5 centimeters square. Okay, what happens is slowly the commissure, this is called commissure. The mitral valve is a big apparatus. So it has a leaflet, two leaflets, mitral ring, chordae tendineae, papillary muscle, and the myocardium, left ventricle, myocardium, that part of the myocardium. So 1, 2, 3, 4, 5. These 5 parts together, we call it as a mitral valve apparatus. So in mitral valve diseases, any part can get damaged with the rheumatic process. Usually the leaflets are damaged first. The leaflets get inflammation here, and the sclerosis, all the fibrin deposits can get settled here, and this starts close. This is called commissure. This is the commissure of the mitral valve. These commissures start getting slowly closing, making the orifice narrow and narrow and narrow. At one particular stage, it may become just like that. And when it reaches 1 centimeter square, we call it as a tight mitral stenosis or severe mitral stenosis. Okay. Then this is about the valve. So what will happen to the chambers? Be there. What will happen to the chambers? If you can just understand this cardiac cycle, you won't forget even the clinical case if it is given to you as in the examination.